Hello, everyone. I'm Gloria Brand, the Director of the Program in Opioid and Pain and Innovation, also known as POPPY, at Brigham and Women's Hospital. Welcome to Part 3, the final segment of Innovations in Substance Use Disorders, a webinar speaker series that has been hosted every other Tuesday from May 23rd through June 20th. We have hoped to have provided you with many unique opportunities to learn more about substance use interventions. And today I have the unique honor and pleasure of introducing our last speaker of the series, Dr. Aimee Moulin. Dr. Moulin is a professor at UC Davis Medical Center in the Department of Emergency Medicine. She is the chief of the Division of Addiction Medicine. Dr. Moulin has a dual appointment in the Department of Emergency Medicine and Psychiatry. She has a master's in applied science and completed a fellowship in quality safety and comparative effectiveness research through the Agency of Healthcare Research and Quality, with a focus on acute care treatment for patients with behavioral health disorders. Dr. Moulin completed and established a health policy fellowship at UC Davis. She is a past president of the California chapter of the American College of Emergency Physicians, and she completed her residency in emergency medicine at the Los Angeles County LAC and USC Medical Center. So without further ado, please join me in welcoming Dr. Moulin, who will be speaking with us today on CA Bridges. Just a little bit about the format for today's webinar. She will be doing her presentation, and then we will be opening up the webinar for questions and answers in our chat, or you can join us as a panelist to ask questions of Dr. Moulin. Welcome, Dr. Moulin.
Thank you. I'm going to go ahead and share my screen so that we can get started. Want to thank everybody for joining us, and also to let you know, if you want to just pop in the chat where you're from, what your name is. I'm really hoping that we can have a conversation and really start to think about how we can do a better job of taking care of our patients with substance use disorders. So if you want to just put your name in the chat, say hello. It's great to see everybody here. So as we mentioned, I'm an emergency physician, and I got into the field of addiction medicine by really realizing this was at the heart of so much of what we see in emergency medicine. But because I came from outside addiction medicine and started to look at this from the emergency medicine view, I think we have a little bit of a different viewpoint and a different approach to people with substance use disorder. So what I'm going to talk about today is our California Bridge model of low barrier addiction treatments. And I think that what you've maybe traditionally heard of as low barrier is probably not quite what we're doing in our emergency departments in California, which I think has gotten to the point where we're trying to be a zero barrier program. So I don't have any disclosures other than to say, looking at the overdose rates across the country, to think that really we couldn't possibly have done worse. To level set at this moment and say, really, things could not possibly have gone worse in terms of starting from a oversupply of prescription opioids, followed by a rapid pullback, overlaid a supply of illicit fentanyl. The pandemic caused a lot of social disruption, that really we are living through what could be considered a worst case scenario in terms of substance use and opioid use disorder. And so this was most recently, we've kind of plateaued at an uncomfortable spot of over 100,000 deaths annually. This past year, the CDC in 2023 says it sounds like over 109,000 overdose deaths, which is a smaller increase, but an increase nonetheless. I started thinking about overdoses in 2015, 2018, and since then, overdose deaths have more than doubled. And so really kind of thinking about the spot that we are in currently, and to think about how we can change the system to do something different, something better. But really also thinking about substance use, particularly opioid use disorder, as an emergency physician, thinking about people who have opioid use disorder have a high risk for death, and that death is potentially treatable. And so every time someone has opioid use disorder and is continuing to use opioids, that is someone who's at high risk for death, and they have an emergent lethal condition that needs to be treated and stabilized rapidly. And so that's the approach that we are taking at California Bridge. And this is a fantastic study done by a brilliant researcher that looked at overdose mortality, and looking at the mortality of patients with a non-fatal overdose. And this really, I think, drives home the point of how lethal substance use is, particularly overdose. So someone with a non-fatal overdose has around a 5% one-year mortality. 20% of the people that die within the first month. And there is a spike in the first 2 days. And so this really revolutionized the way that I think about opioid use disorder, this research paper, to tell us that people with a non-fatal overdose are at high risk for death, and they're at high risk for short-term death. And if I think about the resources and the urgency that I bring to other conditions, like a heart attack, a non-ST elevation MI, to mitigate that risk of death versus overdose patients, really we need to radically rethink how we approach people. And then this is another one to think about, how what we are doing in healthcare is not only not helping people, but potentially causing harm. So as a hospital-based physician, this really means a lot to me. So this is another study looking at death for patients, and then looking back to see when they were previously admitted or discharged from a hospital. And so that we see a lot of patients who do so within 28 days after discharge. So really the thought here is that when someone is admitted to the hospital and we do not address their opioid use disorder, we actually put them at higher risk of death, of overdose. And you can think about some of the mechanisms of that are often their tolerance can be different, or by failing to address the substance use disorder, that can lead to other negative outcomes that could increase their risk for overdose death. So to think about the harms that we potentially cause during hospitalization with unaddressed substance use disorder. And so it really kind of changes the way I think about not providing treatment. Is not only am I not helping, but I could potentially be causing harm. But here's the amazing thing. Despite ever climbing overdose death rates in the country, despite the fact that we can be increasing risk for death, that people have a very high risk for mortality, we have treatment, and that treatment works. And that treatments with buprenorphine or methadone have a 10-fold reduction in the risk of death. So to think about, this is a remarkably treatable disease. And so if you start to look at people with opioid use disorder and recognize we have very effective, cost-effective medications to take care of people with opioid use disorder, it really changes the way that you can think about and approach it. To see every one of those 109,000 people that died last year, those were preventable deaths. And as healthcare providers, it is really incumbent upon all of us to look at the ways that we can decrease that risk of death by providing access to treatment that works. So this is another piece around buprenorphine. So buprenorphine or Suboxone is a partial agonist that is highly effective for treating opioid use disorder. However, grossly underutilized. So this is looking at the comparative effectiveness of different treatment pathways for opioid use disorder. and basically looking at people who overdose and the probability of a second overdose given different treatment pathways. And what you can see is that no treatment is about as effective as some inpatient non-medical detox, that the risk of a second overdose is about the same as no treatment whatsoever. And the one thing that really decreases that risk of repeat overdose is medications, buprenorphine and methadone. So what we can see here is that the medications are remarkably effective, and the medications are more effective than what we commonly give out, which is no treatment or even a no non-medicine detox facility. And just to reiterate how safe buprenorphine, there is a ceiling on respiratory depression. So although it is a partial agonist, there's the ceiling on respiratory depression. So it is a remarkably safe medication. So here we have a life-threatening condition that is highly treatable with a medication that is relatively safe, even at high doses, does not cause respiratory depression like a full agonist. And so my question becomes, why are we not doing more of this? Just to drive this point home, and I'm happy to answer questions about this as well. This was a recent review published in 2021 in the Journal of Drug and Alcohol Dependence. And it looked at 48 years of research on psychosocial interventions. So if you look at what opioid use and substance use disorders are highly undertreated. But often when we do treat individuals, it is not with medications. So in this study, they looked at 48 years and 5 papers, over 54,000 patients. And the conclusion they came to is there is scant evidence available on the putative rehabilitative effects of psychosocial interventions, either as a standalone treatments or an adjunct role to pharmacotherapies. And so really, this kind of drives home to me, what we are doing currently is wrong. And that the primary thing we've currently been doing for the past 48 years are psychosocial interventions that we cannot find evidence to support that they work, when we do know that medications do work. This is the study from the National Survey on Drug Use and Health that showed 10% of Americans with substance use receive any treatment. And then an even smaller fraction of those are offered what we now understand are best practiced evidence-based treatment, which is medications. So we took a look at this and said, no wonder we have climbing overdose rates, because the current system, the system that we have now, is designed to fail. It prioritizes non-medication treatment modalities, has long waits with prior authorizations for a condition that we know is lethal and that has high lethality in the short term. Yet we insist upon complex assessments. We have a very disjointed, siloed model of care with often very restrictive paternalistic treatment models. And so you pull all of this together, and we have designed probably one of the exactly wrong systems to treat a highly lethal disease. And so thinking about, one, we know what works, which is medications, but we have created a system that makes it very difficult for people to access medications. So there's no wonder that we are failing so dismally in terms of providing adequate treatment for substance use disorders, particularly opioid use disorder. So in California Bridge, we looked at the system and said, how can we revolutionize the system of care into one that works for people? To look at what we know and what has been published about opioid use disorder and how we can design a system, or at least begin to hack the system to make it work for patients. So we looked at that high lethality for people who have a non-fatal overdose and the rates of recovery in treatment with medications versus without, and started what we would consider a low barrier treatment model. And what I mean by that is, if you have opioid use disorder, you walk into an emergency department, you are offered treatment on demand. The connection to community care, I believe one of the things that the addiction community has done right, that a lot of healthcare has not incorporated, is the use of peers to provide the warm, patient-centered connections to community care and to really help people navigate the healthcare system from a peer perspective. I think that is one of the places that most of medicine and physical health could learn from our colleagues in addiction medicine, is how to incorporate peers. And really to focus on a culture of harm reduction, to recognize that the first thing we want to do is no harm. And often looking at people with substance use disorder from a paternalistic view of, if you are not doing what I'm telling you to do, I am not going to offer you treatment. But to recognize that we need to meet people where they are, and to move them along. So whatever that person is ready for, that's where we need to meet them. So it might not be that I am ready to start medications today, but we can talk about ways to mitigate harms and to reduce the risk of overdose death and to reduce the risk of infectious disease or other complications that occur from substance use, and to incorporate harm reduction education, harm reduction supplies, sterile syringes, naloxone within regular healthcare. So bringing that culture of harm reduction into our traditional settings for healthcare, emergency departments, hospitals, and primary care clinics, so that harm reduction is not siloed, but incorporated into every aspect of care. So these are the three pillars of the model that we're trying to develop through California Bridge: low barrier access to medications, incorporations of peers, and the culture of harm reduction. So our goal has been to take over all of California and provide, through the emergency departments, 24/7 access to high quality treatment for substance use disorder in all California hospitals. Currently, we started this with this ambitious goal in 2018 with 4 emergency departments. And now in 2023, we are working with 279 of the 310 acute care hospitals in California. And I've often heard from people, yes, you can do that in an academic center, you can do it in an urban center. But one of the things with California is it is remarkable in terms of its geographic breadth, and that we have some very small, very rural hospitals with 6 beds. We have some very small hospitals on the border with Mexico that are very under-resourced with non-English speaking populations, some tribal communities, as well as some highly urbanized centers in Oakland, San Francisco, and Los Angeles. So the model that we have been incorporating in emergency departments in all across California is one that I can tell you is replicatable and scalable rapidly. We have moved from 4 to 279 from 2018 to now. And so this is what we have seen. By incorporating those 3 pillars, the model of rapid access to buprenorphine, peer support, and a culture of harm reduction, we have identified, this is data from 2019 to May 2023, 236,969 patients with substance use disorders. Of those, 176,234 had opioid use disorder. And of those, MAT, buprenorphine, was administered and prescribed for over 76,000 people. What I think is really remarkable about this is, and that is under-recognized, is there is a myth of treatment resistance for people with opioid use disorder. The population of people that we are treating in emergency departments have high rates of homelessness, and between 30 to sometimes 70% of the population that is being treated in some of these emergency departments are people experiencing homelessness, primarily population covered by the Medicaid program. And in different hospitals, somewhere between 15 to 30% of the patients have co-occurring mental illness. So traditionally, a population of people that are thought to be treatment resistant. Yet, when we ask that population of people in the emergency department, do you want help for opioid use disorder? A good percentage of them, almost half, say, yes, I would like help. Today, right now, please start buprenorphine. So 76,000 people said, yes, I want help, I need help, and accept buprenorphine on that ED visit, just because we asked. More than that, this culture of harm reduction, 153,912 naloxone kits were ordered and distributed by hospitals. So naloxone into the hands of the people who most need it are emergency department patients who either have overdosed or at high risk for overdose. So why emergency departments? Really, this is where the people who need the most help. 1 in 10 patients in emergency departments have substance use disorder. They're often not engaged in care. And what we've found from other studies is that providing buprenorphine treatment in the emergency department doubles the likelihood that that patient will be in treatment in 1 month. But really, emergency departments are open 24/7, 365. So someone can always, when they are ready, find a place to access life-saving medication treatment. So really, this is what we do, is universally offer treatment for opioid use disorder, and I will show you what that looks like in a minute. Buprenorphine is started on demand. So there are no prerequisites to start buprenorphine in the emergency department, other than you have a history of opioid use disorder and you are in withdrawal, and buprenorphine is started. So we don't have any prior authorization. There's not a long assessment. Buprenorphine is pretty much started on demand in the ED. And we have incorporated those critical substance use navigators, people with lived experience, to work with patients, provide motivational support, navigation while they're in the emergency department, and then discharge and beyond. And low barrier access to harm reduction with naloxone, sterile syringe exchanges, and then education. So this is what it looks like. Often programs providing substance use or opioid use treatment in emergency departments fail from the beginning, because right off the bat is the first thing folks want to do is implement a screening program. It is really hard to implement screening programs in emergency departments. They are places without a lot of privacy, very time pressured, and universal screening is often instantly killed by the nursing staff. So we took an approach of universally offering buprenorphine. And basically what that is, with patient-friendly signage. You walk into triage, here's a picture of the smiling triage nurse. She has a button, there's a sign that says, do you need help? Ask us for help. And so instead of a universal screening program, we have a universal offer program where patients know that this is a place that people can get help. And so they can self-identify I would like help. People who are also identified can be asked and offered by the clinical staff, but we let everybody know you can ask for help here. So it's universally offering buprenorphine rather than universal screening program. And this is the other key innovation, which is really the incorporation of substance use navigators. These are peer support specialists who work hand in hand with the clinical team to help assist patients, to provide navigation, motivational support, to link people to resources in the community. They become the experts in the local treatment ecosystem and really can help hack the system to work for people. They'll often know which pharmacies people can get buprenorphine in a stigma-free way, because they'll often experience barriers and stigma at different pharmacies. The navigators help with that. They help with transportation, and they really help incorporate the stigma-free, patient-centered approach into a busy acute care hospital. The other part that I think the navigators really benefit our program is follow-up, is the caring contact post-discharge of, hey, did you pick up your prescription? Did you make it into clinic? And if not, no problem, we can try again. And to provide that lifeline for individuals. And what we've found is they've really become lifelines in the community. This is a picture of Tommy Trevino, who is the navigator where I work at UC Davis. And I think that everybody in my city and county has his phone number, and will often reach out if they need help. And we will hear from patients that we helped get into treatment and recovery even years ago, who relapsed, who will then reach back out to say, hey, I need help again. And so they know that we are a safe place to come to get help, to get started on treatment. This is I think the other revolution of California Bridge was recognizing that buprenorphine is a relatively safe medication. And so this is the California Bridge Buprenorphine Emergency Department Quick Start Guide, which is a very relatively high dose of buprenorphine. Most patients receive 16 milligrams of buprenorphine, are watched in the emergency department for about an hour, redosed if necessary, and discharged. So it is a very rapid medication first, medication prioritization model of care. So there are very little barriers other than you walk into the emergency department. If you're experiencing withdrawal, you receive medications up front. Our goal is to get buprenorphine within 15 minutes of arrival. So a door to buprenorphine so that patients can be rapidly treated with their withdrawal symptoms. My goal is to make it almost as easy to start treatment as it is to receive fentanyl, which is really hard because it is extremely easy to access fentanyl and opioids in the community. And so we are at a disadvantage at healthcare. And so as many of the barriers as we can remove, the better. We are at a strategic disadvantage, right? Because it is remarkably easy to order fentanyl off the internet. It can be delivered through the mail, can be delivered in person. So people have easy, ready access to fentanyl. And I need to make sure that treatment is just as easy to access. So we have goals of door to buprenorphine. Patients are prioritized from the waiting room if they're experiencing withdrawal to be brought back into the emergency department, because I know the clock is ticking. So that person who's experiencing withdrawal, if I do not treat them rapidly, will often leave because of the untreated withdrawal becomes uncomfortable for them, and they know how to self-treat, and it is very easy to access fentanyl. So that clock is ticking. I need to rapidly stabilize and provide medications. Similarly, a patient with a non-fatal overdose is someone who we should prioritize and work with to get into treatment and provide more resources to that individual, because I know from previous research that they're at high risk for death. And so this as the other revolution, I think, of California Bridge is almost no barrier access to life-saving medications. And so again, we'll often hear that we're using very high doses of buprenorphine, but the answer to that is 76,000 people have been treated with high-dose buprenorphine on arrival. And so the answer to this is people want help, and we can provide them rapid access to medication treatment through emergency departments. And this is, if you are interested, California Bridge has a bunch of clinical protocols, a whole website dedicated to acute care treatment of substance use disorders, including rapid quick start guides for alcohol, for opioids, for stimulants, incorporation of harm reduction practices, training for clinicians and substance use navigators to change the way that we approach people with opioid use disorder to a rapid access to medication approach, incorporating harm reduction, and then incorporating people with lived experience into the everyday aspect of clinical care. And really, this is the thing that I want to leave you with when we turn it over to questions, is this is really the goal, is that all people deserve rapid access to addiction treatment. And the goal here is to provide access to medications in a way that is open and almost as easy as it is to get fentanyl. So because we're at that disadvantage, we really need to make it easy to access medication treatment. And then because we know that medications work and are evidence-based in terms of reducing the risk of death, all treatment should prioritize access to medications. And with that, I'm happy to pause and turn it over to questions.
Thank you, Dr. Moulin. That was an amazing presentation. We really appreciate your time today that you took to offer this information to us. And we want to now, like she said, open up for any questions and answers. Feel free to put your questions in the chat and we will give those to Dr. Moulin, or if you would like to come on as a panelist to ask your questions in person, that is also welcome.
And I'll go ahead and kick it off while the questions are coming in. First of all, thanks for everyone that attended today. I know yesterday was the first time we celebrated Juneteenth as a holiday. So this is like a Monday for a lot of people in the hospital. So thanks to those of you who made time. We will definitely we've recorded this and we'll make it available to people because, Aimee, there's so much good information here. And this is such a perfect ending to our Innovations in SUD series, because this really is an innovation. And you've touched so many lives and you've inspired so many of us, because it's basically, if you had said, how can you get this done on a large scale, I would have said it's impossible. But you've done it in California, which is enormous, right? One of our most populous states, reaching nearly every ED, and you've really shown that it's possible. So I do have several questions to ask, and I hope that some people from the audience also ask some questions too. So feel free to put them in the chat if you'd like to do that. But my first one is of course there's like two big problems right now. There's fentanyl and funding. So maybe I'll ask the fentanyl question first. So we've had fentanyl up here in the Northeast for a long time, probably seen it for a longer time than you've seen it out west. But I know that with changes around COVID and everything else, it seems to be just taking over the whole country. And so We're starting to see cases of some precipitated withdrawal with lower COWS scores, with patients being less willing to take buprenorphine because they're worried about precipitating withdrawal. Have you noticed those trends in California as well, or are things still going well with buprenorphine there?
Yeah, so I think we have to really be careful to think about precipitated withdrawal. I have definitely had some cases of precipitated withdrawal of people who experience a lot of autonomic instability, who become very sick, and we have to treat them pretty aggressively. And undertreated withdrawal, I think it's absolutely true that people who use fentanyl require much higher doses of buprenorphine. Whereas before, I think most people stabilized on about 16 milligrams a day, 8 twice a day. I think with fentanyl, people really need 24, 32, much higher doses of buprenorphine. And so there's two things. One, I think there's a group of people that have been undertreated. I think that there's definitely word has gotten out in the community of people who say, oh, buprenorphine doesn't work for me. And I will talk to them about, well, what was the dose that you took before? And sometimes people were only given 8 milligrams. And we all know that's just not going to cut it for someone who's using fentanyl every day. And so to really just say, okay, and my approach to dosing for someone is, I want to give you the dose that makes you feel comfortable, like you're going to be successful. I don't really care how much it is. Whatever the dose is that makes you feel comfortable and like you are going to be successful in treatment is the right dose for you. So I don't really have a ceiling in terms of if escalating doses of buprenorphine are causing people to feel better, go ahead and give that. And then the other part that I think is the real challenge is the longer time course to withdrawal. So previously, and I don't know if this is your experience with heroin, it was just within a day, someone experienced withdrawal. You could give buprenorphine. It was very easy. Fentanyl, it will often take 2 to 3 days of abstinence from fentanyl before that person will experience withdrawal and be able to be started on buprenorphine, that sort of lower cow score phenomenon. So we have approached that with 2 strategies. Sometimes we will hold people for observation for longer and give them full agonist to help bridge them, a short-acting full agonist, and then start a really high-dose buprenorphine. So kind of a longer cross taper with full agonist in the ED or OBS unit or in the hospital, or give folks, that full complement that we used to do of comfort medications of clonidine, benzos, ibuprofen, and have them come back to start buprenorphine later. So I think it's really a timing issue for at least what we've developed, those 2 approaches. One is sort of the longer cross taper with full agonist, and the other is waiting and then higher dose buprenorphine.
Yeah, it's helpful, and it kind of gets to, again, my second question, which was around funding. We've actually wanted to admit some people to observation for opioid withdrawal. There's challenges with billing for that, with reimbursement for that, and then just overall, I was hoping you could talk about that, because we're very fortunate at our hospital because we've had donations that have allowed us to sustain our bridge clinic, and we have peer recovery coaches who are incredible and life-saving and transformational. But by itself, the program is not self-sustainable. And I think that's probably
right. So this is the thing that drives me the most nuts, right? So here, we have a crisis in this country of escalating numbers of people dying, young people dying, right? The range of people who die of overdose is remarkably young. And we have data to show what works. Medications, buprenorphine. So I have here a escalating problem for which I know the solution, right? And that is buprenorphine. There are some different strategies that might require OBS admits, maybe some admissions, some cross taper, solvable problems. You also have funding streams from the federal government, from opioid settlement money. And here's the thing, 9 out of every $10 are going to programs that do not prioritize medications that we know don't work. 48 years, 54,000 patients, no evidence that it works. So 9 out of every $10 is being redirected to, as far as I can tell, primarily ineffective programs. And so what we really need to do is talk about, hey, this is a solvable problem, and to really all come together with that message of we need to redirect those dollars towards what we know works to save lives. So from a practical standpoint, yes, we are looking at opioid settlement funds, which in California primarily went to the counties, to prioritize that those funding go to evidence-based treatment. And then in terms of the observation admission for opioid withdrawal, Off the record, yes. So sometimes we'll do an observation admission for intractable nausea and vomiting associated with opioid withdrawal. So there are different ways to approach the symptoms of opioid withdrawal that can meet criteria for an inpatient observation stay or an ED observation stay. But I agree with you. We shouldn't have to do that. It's a life-threatening condition. We know how to treat it. There's money out there. It's just being used in ineffective ways, in my opinion.
Yeah, you're preaching to the choir there, and there's no question about it. And I wish we'd come to that realization that by not putting the money up front to
Right.
people are dying and we're spending much more. I don't need to convince you about that.
No, but I do think we all need to start saying, hey, you know, I think we've been a little bit softer in saying, hey, you know, some of these other programs maybe worked for people, but to look at the data and say, you know what, that's not evidence-based and we need to prioritize medications. We owe it to the people who are dying.
And so it's yet another question. So you had the slide of the pharmacy and said, you know, systems are designed, they're set up for us to fail. And we recently published a paper that looked at buprenorphine availability at pharmacies. We found that it was very suboptimal. In fact, in California, less than half of the pharmacies, of over 700 pharmacies that were called, actually reported carrying buprenorphine. Mm-hmm. And there's a whole host of reasons why they say they wouldn't carry it. And some of it was stigma. Some of it is related to distributors who are really scared. Some of it's related to DEA policies. Some of it's related to PBMs, how the pharmacies get paid for it. So my question is, are you having trouble with that where you start patients in the ED and then they're not able to fill it later?
100%. So I get that pharmacies were hammered in terms of the opioid epidemic, and several of them are paying out settlements for bad behavior. But the pendulum swinging of refusing to give out medications to treat it, I think has gone too far. So you're absolutely right, which is why, unfortunately, we also have to have not just a list of places where people can go for outpatient treatment, but a list of pharmacies where they can pick up their prescriptions for buprenorphine, and that we have to be selective about where we send prescriptions, which is 100% wrong, right? Because it should be the other way around, that pharmacies who were a part of the opioid epidemic should have a part in treating the opioid epidemic. And so I think one, it's corporate policies of fear, maybe some misguided fear of retribution from the DEA, and stigma, right? There's just the thought that we don't want those people in our pharmacies. And so it's a lot that we have to combat. If I hear of pharmacies that are bad actors, we will report them. We will call them and try and work with them. But really, yes, I have to keep a list of pharmacies that will provide treatment to their patient population, which is really unfortunate and can be difficult for people in rural areas. We have some folks who live in some very rural settings who have a clinic that will treat them, but then have to drive several miles to find a pharmacy that will actually fill their prescription.
It's so tragic. And if you think of any other medical condition, it just wouldn't happen like that, right? It's shocking, but actually, Gloria, are there any questions for the audience by chance?
No, it doesn't look like we have any questions from the audience at this point.
Okay, I'm going to keep going if that's okay, Aimee. Because I love picking your brain. So, there's this issue with convincing emergency physicians that it's like, if you build it, they will come. And I think people are scared of that. But there's actually been some studies that show that when they build programs like this, recidivism actually decreases. And so I was curious of your experience with that across California.
I think it's a myth. Well, I think both is a myth. I think there's the first myth, which is emergency departments won't do this and emergency physicians won't do this. And I think that is really the revolution of California Bridge that shows if you make it easy for them, they will, right? So at this point, we're working with most emergency departments across California. And I have to say the willingness of emergency departments and emergency physicians to accept change and to change their practice and the rapidity with which they have done that in California is remarkable. And so there is a myth that emergency physicians won't do it. I think that we've really shown that that is false. And certainly, yes, there's a lot of fears. Emergency departments are extremely overwhelmed, underfunded, under-resourced. And so the first thought is like, how are you going to make my life harder, bring in more patients? And so really the way that we have been successful, at least in California, is to make it really easy and provide more resources for people to provide care. And so the first is the fear of the zombie apocalypse, which is if you build it, they will come and your waiting room will be overrun by buprenorphine seekers. And that's just not true. It hasn't happened in any emergency department that we have seen. Also, I tried really hard to create the zombie apocalypse. Way back in 2018, I forced my entire department to get X waivers. So they all sat through this 8-hour course, which I forced them to do, and nobody was happy with me. And then I thought, well, I have to make it worth their while. Like, what if they went through all of this and nobody ever comes in for buprenorphine? So I went out into the community. We went to encampments. We went to places where people were purchasing drugs, and we passed out cards. Come to UC Davis, come to UC Davis. We want you at UC Davis, please come. I partnered with non-medical detox facilities. Send me your patients, we'll help start them on buprenorphine. I went to the jails. If you release someone, you just send them right over to UC Davis and we will start them. I tried as really hard as I possibly could to drum up as much business as possible. And we start about 2, sometimes 3 people a day on buprenorphine, mostly through Fast Track.
That's still a lot. I mean, it's like in a good way. We're seeing like 6 per month usually. So we're prescribing.
Okay, so yes, so we start 2 to 3 people a day. Word has gotten out, but people understand. They come to UC Davis, they show up in triage, they say, I'm here to start buprenorphine. They know to come in withdrawal, and so they'll often come in. We will start them in Fast Track. The average length of stay is about 2 hours.
Yeah, brilliant.
So it's a really rapid turnaround. People feel excited to do it. It's a highly gratifying patient population who often says thank you, who feels better. And then for the most part, we don't see that person again. We may see them again in 5 years if they need help again, or they'll come back and bring their loved ones, friends, family members. But it's much easier than having a person come in with cyclic vomiting or abdominal pain that is unwilling to tell you that they're in opioid withdrawal that requires IV CT scans. So it's very easy. A lot of my faculty enjoy taking care of people with opioid use disorder, and a lot of them have gone on to become boarded in addiction medicine because they enjoy taking care of this population. So I think it has become from how can you ask me to do something more to I really enjoy this part of my practice.
Yeah, and I think you get down to the root of stigma as well, which is that I think it's that as physicians and other healthcare providers, we had nothing to offer. And that was really hard and really frustrating. And I think that perpetuated stigma too. And now I think we do, which is amazing.
It's the codependency of physicians, particularly in emergency departments, is I want to help people and I like taking care of people I can help. And so for a really long time, this people with opioid use disorder felt like a large unsolvable problem. But honestly, we were told that there was nothing we could offer because this person needed to be in counseling and have this long, assessment, and that they really needed to overcome all these barriers. And there was nothing that I could do. And so I think it became feeling this hopelessness that we took on as providers versus now being able to be a really important lifeline to someone to be able to change their life and decrease their risk of death is very gratifying.
Yeah, I think that's a great way to conclude as well too. So thank you. Can I say a couple more things, Gloria? Is that okay?
Sure, go ahead.
Okay, first of all, just the California Bridge website, cabridge.org, I believe is incredible. It's got tons of resources for people. I rely on it all the time. So please check that out. The second thing is just a reminder that we just released our RFA for our annual McGraw Innovator Awards, which is we're going to give out 2 $25,000 awards to kind of high risk, high reward type projects regarding either opioids, pain, anything related to substance use disorder. That just opened up. We just need a letter of intent, which is pretty brief to qualify. So please reach out to Gloria if you're interested in that opportunity. It has to be internal to at least one person internal to the Brigham.
No, thank you for that, Scott. And thank you again, Dr. Moulin, for a very passionate presentation. I really do appreciate your passion for this work. It goes a long way in these types of presentations. And in terms of what we'll be doing moving forward with our series, we will have these recordings posted on the Poppy website. I'm putting the actual link to our events page within the chat. And then we'll also be forwarding the recordings via our mass distribution list as well, so that you guys have an opportunity to look at this in your spare time, and others can look at it as well. So we really appreciate you again, Dr. Moulin. Did you have any last comments?
Nope. Thank you. Really enjoyed being here, and good to see you both.
No, thank you. Thank you, Scott. Thank you, everyone.
Thank you so much.